disorders webinar. My name is Rنيم المطيري and I'm going to be your lecturer for today. So the first topic that we'll be discussing today is the hypopituitarism and the nutritional management in these cases. We will start our discussion with some definitions and background information regarding this topic. First of all, hypopituitarism is an underactive pituitary gland, and any deficiency in the production of the pituitary hormones may be caused by tumors, trauma, radiation to the brain, or even stroke and aneurysm, or to a simpler cause such as surgery. So in the hypopituitarism, there is a lack of one or more of these hormones and a loss of function in the affected gland or organ. So it may take years for an accurate diagnosis to be made in this case. And if all pituitary hormones are missing, then this will be called panhypopituitarism, which is considered as a relatively rare disorder. So an adrenocorticotropic hormone stimulates the adrenal gland to release the cortisol and to maintain the blood pressure and the blood glucose levels in these patients. So if this hormone is missing, then depression, fatigue, low blood pressure, nausea and diarrhea, or even dizziness with pale skin and weight loss are to be signs of this disorder. Hi, نادرة حسيت بمشكلة في النت. So as we were saying, if this hormone is missing, then several symptoms can develop in these patients. So a shortage of the cortisol can be life-threatening, and having the arginine vasopressin hormone was formerly known as the antidiuretic hormone. So AVP can control water losses by the kidney, and if it was deficient, then a severe thirst and excessive urination can occur with diabetes insipidus as a side result. So in rare instances, deficiency may occur after an event such as brain surgery. So the symptoms of pituitary disorders include headache, depression, mood swings, abdominal pain or anorexia, loss of memory and loss of sleep, and failure in lactation. So the growth hormone can regulate the somatic growth, carbohydrate, and lipid metabolism, in addition to adipocyte function. So there is a complex interplay between the growth hormone and insulin signaling, and if it was deficient in children, then short stature can result as a side effect. And this condition can cause 10% of all cases of dwarfism, where in adults there is an abnormal body composition such as osteopenia, impaired quality of life, cardiac dysfunction, and adverse lipid profile. while for the follicle-stimulating hormone and the luteinizing hormone, they control the sexual function and fertility in both males and females. And the gonadotropin deficiency occur in men and women as well, and can experience fatigue, weakness, loss of body hair, impotence in men, and loss of menstruation in women. While the oxytocin stimulates the uterus to contract during labor and produce milk from the breasts. So prolactin will stimulate the female breast development and milk production, and its deficiency is rare, but it can stop the milk production in women after giving birth. While the TSH can stimulate the thyroid gland to release hormones which affect the body metabolism. And when it is deficient, this can lead to an underactive thyroid, which is known as hypothyroidism. This will also lead to cold intolerance, constipation, weight gain, and pale or even waxy or dry skin can occur as a side effect. So for the intervention, we will aim to replenish any missing hormone, prevent dehydration, hypoglycemia, and any related problems. Also improving the lean muscle mass stores and monitoring the serum levels of cholesterol and triglyceride to prevent the vascular complications. And for food and nutrition, we need to have dietary alterations that may be needed, such as having higher or lower energy intake depending on the condition until the hormone levels are normalized with modified fat, cholesterol, and carbohydrate intake that may be needed. Also, we need to ensure that there is sufficient intake of protein in particular. And having 6 small feeding may be better tolerated than larger meals. And increasing fluid unless if it was contraindicated, with ensuring adequate intake of all vitamins and minerals. Also, calcium and vitamin D should be taken in sufficient amount to prevent the development of osteoporosis. So some of the common medications that are used in this case and their potential side effects include any of the following. In the case of corticosteroid, they are often used and can alter the glucose, calcium, and phosphate tolerance. Also, potassium and polycin must be increased, and the sodium must be decreased to monitor the signs of hyperglycemia. So thyroid preparations can also be needed in this case, and growth hormone requires no specific dietary intervention, but it can help in elevating the elevated triglyceride level, but its long-term replacement therapy in adults is considered to be safe for lifelong management in order to maintain the health benefits. And for herbs and potential supplements, it shouldn't be used without discussing it with the physician. Therefore, we need to ask the patient in specific if they are using any type of medication or herb supplement on the side of their medication intake. So for the nutrition education and counseling, we need to have the patient to avoid fasting and stress at all times. Also, we should discuss the need to use small, frequent meals instead of larger meals, and discuss the possibility of hyperglycemia and how to manage it if it was to develop. In addition, hormone replacement is usually permanent, so the doctor visit will be needed to check for any diabetes that may develop during the course of the treatment and signs of osteoporosis. And for patient education in regard to foodborne illnesses, if the patient was using home tube feeding, then we should teach them to have appropriate sanitation and food handling procedures. Another major concern in thyroid disorder is acromegaly, and we will be discussing this in a nutritional related point of view. So, acromegaly is defined as a hormonal disorder that is caused by overproduction of the human growth hormone by the pituitary gland. And the incidence is very rare, with about 50 to 70 cases per 1 million person in the US alone. So the diagnosis is made with the comment about a decade after the oversecretion of growth hormone that begins. So if the growth hormone producing tumors occur in puberty, then the condition is called gigantism. And the genetic and the nutritional impact of the height of the most children is unusual, and continuing growth in the stature beyond the 20s should be evaluated by assessing the growth hormone production. So growth hormone, the somatotropin, affects the growth of almost all cells and tissues in the body, and has a direct and indirect effect on the body tissues and cells. So the direct effect of the excessive growth hormone include hyperinsulinism, lipolysis, as well as insulin resistance in the peripheral tissue, ketogenesis, hyperglycemia, and sodium with water retention. So in over 98% of the cases, overproduction of growth hormone is related to a benign pituitary tumor. And in a few patients, acromegaly is caused by tumors of the pancreas, the lungs, or the adrenal gland. So the symptoms and signs of acromegaly include enlarged extremities with disappropriation of the growth of the nose, lips, brows, and lower jaw, in addition to the tongue, hand, and feet. So the serious side effects include heart failure, colon polyps that become cancers, in addition to diabetes in some cases. So the elevated insulin-like growth factor also occurs in acromegaly, resulting in a greater protein synthesis, amino acid transportation, muscle and bone growth, in addition to DNA and RNA synthesis with cell proliferations. So having high level of growth hormone and increased level of IGF-1 levels, about 3 to 10 times above the normal range, can be used to diagnose acromegaly. So the hormone secreting pituitary tumors account for about 30% of all pituitary tumors, and surgical removal of these glands will provide about 50 to 70% chance for having a cure. So acromegaly is complicated by an increased incidence of diabetes mellitus caused by impaired insulin sensitivity, in addition to reduced beta cell function. So bone and cartilage growth may lead to arthritis, and these patients can present with hypoadenocytopenia, and studies suggest that a link between adiponectin, basistin, fat mass, and bone changes is related in this type of disease. So having premature death can result if left untreated. In addition to treatment may include surgical removal of the tumor or radiation therapy, or even injection of growth hormone blocking medications. So having somatostatin analogs have been used as a key in the medical therapy. Also, bivomystin, which is a GH receptor antagonist, is competitively binding to the GH receptors, blocking the IGF-1 production and allowing a better control of the cardiac disorders and the glucose metabolism. So improved insulin sensitivity will occur after the use from a reduction in overnight endogenous glucose production. And having somatolene depot, which can be used for long-term treatment option in patients with inadequate response to the surgery or to radiation, can be used as an additional therapy method. So the intervention objective include having a controlled body weight, preventing or controlling diabetes, as well as hypertension or heart disease when they are present. Also preventing osteoporosis with calcium balance, which is often negative in these patients, as well as monitoring for complications such as colon polyps, which may lead to cancer in the extreme cases. So for food and nutrition, having carbohydrate control diet may be needed if diabetes is present, as well as having extra fluid intake that might be needed, and controlling for sodium and fluid intake if the patient has heart failure, as well as offering sufficient intake of calcium and vitamin D with having multivitamin or mineral supplementation that may be useful in some cases. So some of the common medications that are used and their side effects include brochroptine, which can be taken orally to reduce the growth hormone secretion. And side effects include gastrointestinal upset, nausea, vomiting, lightheadedness when the patient stands, and nasal congestion. So this type of medication should be taken with food to avoid or to reduce these side effects. Also, having cardiac medication may be needed for some patients, but we need to monitor for specific side effects accordingly. If the patient was using atorvastatin, the treatment is safe, well tolerated, and effective in most cases, and doesn't have many side effects. Also, bigvestin is used to normalize the circulating level of IGF-1, and the principal mediator of the growth hormone action is this medication. Also, having somatolene depot delivers in an injection subcutaneously instead of into an intramuscular injection will have side effects including diarrhea, abdominal pain, nausea, injection site reaction, fluctuation in the levels, and arthalgia with loss of stool. And for herbs and potential supplements, it shouldn't be used without discussing it with the physician first to avoid any medication interaction and any possible side effect that the patient can misreport. And for the nutrition counseling, we need to discuss the body changes and altered self-image in specific. Also, we need to recommend exercise, which can help improve the physical functioning, in addition to the quality of life. We should also teach the patient about control of diabetes or heart failure when it is present, And after surgery, potential complications can include cerebrospinal fluid leaks, meningitis, as well as damage to the surrounding normal pituitary tissue, requiring therefore lifelong pituitary hormone replacement. And for the nutritional therapy for Cushing's syndrome in specific, first of all, we need to define Cushing's syndrome, which is a disease caused by an excessive cortisol, and it can be caused by extrinsic and excessive hormonal stimulation to the adrenal cortex by tumors of the anterior pituitary and adrenal hyperplasia or even exogenous cortisol use. So having differential diagnosis is not simple, and no existing tissue is accurate when it is used alone, but focusing on the imaging and including CT scans and magnetic resonance images and even a nuclear imaging modulating can provide diagnosis. So the pituitary CS occurs after puberty with equal frequency in boys and girls as well. And in adults, it has greater frequency in women than in men, with most diagnosed between the ages of 20 and 50 years. So the total incidence is about 10 to 15 million people per year alone, and it is considered as a disorder that is characterized by virility, upper body obesity with thin arms and legs, in addition to hyperglycemia, glucosuria, hypertension, red moon face, vertigo, and emotional liability or buffalo hump and verbose diarrhea over the obese area, acne in addition to female balding, and blurry vision or beating ankle edema. So in some cases, osteoporosis and severe depression are present, and therefore appropriate management need to be considered in these cases. So the chronic cortisol hypersecretion that causes the central obesity and the hypertension, in addition to insulin resistance, dyslipidemia, and prothrombotic status, is the manifestation of the metabolic syndrome. And there is a complex interaction between Cushing syndrome and inflammation, as well as raised level of IL-8 and OBG in patients with Cushing syndrome. Also, despite the glucocorticoid excess, it may present with an inflammatory and pro-atherogenic phenotypes. So if it was left untreated, Cushing syndrome can be fatal, and its diagnosis is usually not simple. So having late night salivary cortisol may be used as a useful test, and treatment will differ according to the cause of the syndrome. So in the ACTH-dependent disease or the N-independent disease, or even the iatrogenic from an excessive steroid hormone use, are three different types, and accordingly, the treatment method is to be decided. So if the iatrogenic depletion of the steroid hormone will be needed in this case as a treatment method. And if the pituitary is the cause, then the gland may need to be removed as a treatment method for this case. So, Cushing syndrome caused by ACTH production from the solid tumors can result in life-threatening hypercortisolemia, and having radiation, chemotherapy, or even surgery may be needed. So, after surgical removal of the adrenal gland, most symptoms of Cushing syndrome will disappear. And having psychological impairment can persist despite successful treatment options as a possible side effect of the condition. So for the intervention objective, we will aim to control the elevated blood glucose or lipid levels by managing the diabetes and cardiovascular diseases. Also, we need to promote weight loss if the patient was obese, decreasing fat stores while increasing the lean body mass by exercise is always recommended. Also, we need to control or even lower the blood pressure if the patient had hypertension. And we need to prevent or control side effects of corticosteroid therapy, having vertebral collapse or heart failure, in addition to bone demineralization or osteoporosis and hypokalemia. So for food and the nutrition, we need to restrict the sodium if the steroids are used, in addition to using an emergency controlled diet if needed, with having calculated diet according to the patient's desirable body weight and medical condition. So controlling the glucose level when it is elevated by having carbohydrate counting as a useful intervention method. In addition to this, we need to ensure adequate intake of calcium and potassium and adequate intake of protein if the losses are excessive. This can be calculated by 1 gram of protein per kg or more depending on the case. And finally, we need to use an anti-inflammatory diet that is rich in omega-3 fatty acid and specific herbs and spices that have antioxidant properties. And some of the common medications that are used, in specific with glucocorticoid therapy, osteoporosis, and hypercalciuria are a common side effect. And having withdrawal of these medications after autoimmune or cancer management can cause iatrogenic Cushing syndrome. Also, adrenal insufficiency or steroid withdrawal symptoms can occur in this case. And having large doses of vitamin D may be necessary, but we shouldn't use for extended period without monitoring for toxicity side effects. And for herbs and potential supplement, it shouldn't be used without discussing it first with the physician to avoid the development of any side effect or any medication interaction that would lead to worsening of the patient's condition. So for nutrition counseling and care management, we need to help the patient control their weight as needed. Also, we should explain which food are good sources of calcium in the diet and explain in specific how to control the elevated blood sugars and lipid through having a balanced dietary intake in specific. Also, managing symptoms of metabolic syndrome through dietary changes and exercise is recommended. And for patient education regarding foodborne illnesses, if the patient was using home tube feeding, Then we need to teach them about appropriate sanitation processes and food handling procedures. Another topic that we'll be discussing is Addison disease and its aspect from a nutritional point of view. So in adrenocortical insufficiency, the adrenal cortex atrophies with loss of the hormones, including aldosterone, cortisol, and androgens can develop. So having a primary adrenal insufficiency in the pediatric population is most commonly attributed to congenital adrenal hyperplasia. This occurs in about 1 in every 15,000 births, followed by Addison disease and with a likely autoimmune etiology. So having a secondary form will often result from tuberculosis, cancer, or surgery in which the adrenal glands are destroyed or even damaged. So of the patients with adrenocortical insufficiency, about 33% will also have diabetes as a side effect of the condition. And with type 1 diabetes, the expression of the organ-specific autoantibodies is very high. And this will suggest a need for having careful screening in both of these conditions to avoid any side effects from developing. So cortisol, which is a glucocorticoid, will affect almost every organ and tissue in the body, and it can help the body to respond to stress. So among other tasks, having cortisol will help to maintain blood pressure and cardiac function, as well as the immune system inflammatory response and the effect of the insulin breaking down the sugars for energy through metabolism of the macronutrient and having proper health and well-being. So aldosterone will functions to conserve the sodium and excrete the potassium. And when it is no longer secreted, the following event will develop, including excretion of sodium, which will take place, and the body stores of water will decrease, which can lead to dehydration, hypotension, and decreased cardiac output. So the heart will become slower due to reduced workload, and increased serum potassium will lead to arrhythmia, arrest, and even death. So having primary adrenal insufficiency will causes abdominal pain, vomiting, weakness or fatigue and weight loss, dehydration, nausea, diarrhea, and hyperpigmented skin. It can also causes hypotension, low serum sodium, high serum potassium, and low corticosteroid levels. And it may be temporary or even can become chronic insufficiency, and having salt craving can develop as a side effect in these patients. So in type 1 primary adrenal insufficiency, which is also called as the polydipron deficiency syndrome, it occurs in children and can exhibit underactive parathyroid gland. In addition to pernicious anemia, chronic candida infection, chronic active hepatitis, and slow sexual development. In addition, the autoimmune thyroid disease are often associated with type 1 diabetes and Addison disease, characterizing the autoimmune polyendocrine syndrome in these cases. While type 2 primary adrenal insufficiency can affect young adults and present with underactive thyroid gland, slow sexual development, diabetes, vitiligo, and changing in the skin pigmentation. So in the secondary adrenal insufficiency, which is much more common than the primary form, there is a lack of the ACTH. So having production of cortisol drops, but not the production of the aldosterone, and having temporary form for the secondary adrenal insufficiency can occur when a person has been receiving glucocorticoid hormone, such as prednisone, for a long time treatment, but stopping or interpreting the medication intake can lead to some side effects. So glucocorticoid hormones, which are often used to treat inflammatory illnesses such as rheumatoid arthritis, asthma, or even ulcerative colitis, can block the release of both CRH and ACTH. And normally the CRH instructs the pituitary gland to release the ACTH. So if the level of this hormone drops down, the pituitary is not stimulated to release ACTH, and the adrenal will then fail to secrete sufficient level of cortisol. While in the secondary adrenal insufficiency, darkening of the skin doesn't occur, and having GI symptoms are less common. So hypoglycemia, anxiety, nausea, and palpitation can occur as side effects. So Addison disease in specific is defined as a strict insufficiency state of the adrenal hormone, including the cortisol and aldosterone. And it can affect about 1 in every 100,000 people. And having autoimmune Addison disease is caused primarily by having autoreactivity toward the adrenal cortex. So the T cells seem to be involved in this process. And the Addison disease crisis can be precipitated by an acute infection, even trauma, surgery, or excessive body salt loss. And for patients with adrenal insufficiency, even though there is no treatment, they can have poor quality of life and increased mortality rates. So a normal lifespan is possible if there is daily medication that are taken as prescribed, and having delayed and sustained release of oral formulation of the hydrocortisone will match the more natural circadian rhythms of the body. Also, having a delayed and sustained release of these formulation with adrenalectomy can require steroid replacement therapy with 2 grams of sodium diet restriction and control of the carbohydrate intake to prevent the development of hyperglycemia. And possibly the addition of dehydroandrosterone to the treatment plan may lead to improved well-being and sexual function in these patients. And for the intervention objective, We need to relieve the symptoms of the hormone deficiency by taking synthetic hormone, but not in excess. Also, to prevent hypoglycemia by avoiding fasting, as well as preventing weight loss and improving appetite and strength. So, modifying sodium according to the drug therapy and preventing hyponatremia, especially during warm weather when the sodium losses from precipitation are higher than usual. Also, we need to prevent dehydration and shock from developing, as well as preventing or correcting diarrhea, hyperkalemia, nausea, and improper medication administration. So if hyperglycemia or diabetes develop, insulin may be needed in these cases. And for food and nutrition during adolescent crisis, low blood pressure and low blood glucose level with high level of potassium can be life-threatening. Therefore, having intravenous injection of hydrocortisone, saline, and dextrose are given by the medical team. Also, using high protein, moderate carbohydrate diet and snacks may be needed. In addition to controlling carbohydrate amount and frequency according to the blood glucose and the A1C levels. We need to also ensure having the intake of sodium that is adequate according to the medication given, and to monitor for the potassium levels and adjust the diet as needed. And most importantly, we need to ensure that the patient have enough fluid intake when it is allowed by forcing up to 2 or even 3 liters of water on a daily basis. So the common medication that are used, if aldosterone is missing, then having fludrocortisone is used as an oral synthetic sodium-retaining hormone. And we should be aware about overdosing of these medication with the potential side effects of hypertension and ankle edema. Also, postural hypotension can occur with a dose that is too low, and having extra may be needed when exercising or when the weather is hot. So having long-acting synthetic glucocorticoids such as oral dexamethasone or prednisone are given for replacement therapy. And side effects can include loss of calcium, decreased bone density, or even risk of osteoporosis. And to reduce or to decrease the gastric irritation, we should take hormones with milk or an antacid to avoid any possible side effects. So signs of insufficient amount of cortisol replacement therapy will include feeling weak and tired all the time, as well as getting sick or vomiting and anorexia with weight loss that can develop in some cases. And for herbs and potential supplements, it shouldn't be used without discussing it first with the physician, and we should ask the patient in specific if they are using any supplements. While for the nutrition counseling, we should help the patient to individualize diet according to the symptoms, and during these illnesses or injury, the body will normally make up to 10 times more cortisol than needed. So to be prepared, we should avoid the crisis with appropriate treatment immediately to avoid any more complication from developing. Also, we need to ensure that the patient doesn't skip meals and instruct them to carry cheese or cracker snack to prevent the development of hypoglycemia. And we need to discuss the simple meal preparation to lessen fatigue as much as possible. And most importantly, we need to discuss food sources that are rich of calcium and potassium according to the medical plan that have been described to the patient, as well as the use of a medic alert identification that is recommended. So patients with this condition may need to carry a syringe pre-filled with dexamethasone in specific conditions. Also, pregnancy is possible with carefully managed replacement medication, and evidence has occurred that fracture risk might be programmed during intrauterine life. So, mediated through puberty, dependent with the endocrine system such as insulin and growth hormone, with HPA system can develop in these cases. Also, if the patient was using home tube feeding, we should instruct them about having sanitation processes and food handling procedures. So hyperaldosteronism is defined as an increased production of aldosterone by the adrenal cortex. And the adrenal aldosterone, will control the water and electrolyte balance by acting on the mineralocorticoid receptors in the kidney and also in the vascular system. So hyperaldosteronism will cause the endothelial dysfunction regardless of the high blood pressure. And patients may be quite vulnerable to cardiac events, including stroke in these cases. So the primary aldosteronism is usually from an adenoma and involves the hypertension, hypokalemia, and low plasma renin level. While the familial form of hyperaldosteronism type 1 represents about only 1% of all cases of the primary hyperaldosteronism. And it may be detected in asymptomatic individual with screening the offspring of the affected individual, or even the patient may present in infancy with hypertension, weakness, and failure to thrive due to hypokalemia. So it is considered inherited in an autosomal dominant manner. So the Conning syndrome is considered to be a benign tumor in one adrenal gland that can cause this condition. And having the urine 18 hydrocortisol measurements are used to detect this condition with adrenal adenoma or the glucocorticoid suppressors hyperaldosteronism. While in the secondary forms of aldosteronism, it may occur after cancer therapy, heart failure, hyperplasia, or malignant hypertension, pregnancy, estrogen use, or cirrhosis. And aldosteronism is a diagnosis that should be considered in refractory hypertension cases. So having CT, MRI, and adrenal vein sampling will distinguish the unilateral BA form from the bilateral form. So the unilateral form can be treated surgically, whereas the bilateral form is treated medically. And for the intervention objectives, we need to hydrate the patient adequately and alter diet as needed, as well as correct hypokalemia and hypertension by also preparing the patient for surgery if a tumor is involved, or in the case of laparoscopic adrenalectomy that is quite successful, after which we need to have the blood pressure control to return to normal. And if the tumor is not involved, then medical treatment will be for life. And for fluid and nutrition intervention, we should provide adequate fluid intake unless if it was contraindicated, for example, in the case of renal disease or heart failure. Also, having a sodium restricted diet may be needed, and having high potassium intake and the DASH diet may be required in these cases. So, this will depend on the medical or surgical treatment that is used. And most importantly, we should have small frequent feeding to avoid hypoglycemia from development and to reduce consuming large amount on the main meals. And for the common medications that are used, it includes antihypertensive, but we should monitor for side effects that are specifically for the medication prescribed. For example, aldosterone antagonists have been available for many decades, and the spironolactone can be used as well alone or with ACE inhibitors or ARBs. Also, the elobrin, which is a selective aldosterone antagonist, will avoid the androgen and prostaglandin receptors that relate to adverse events, also that sometimes occur with spironolactones. These can include breast tenderness, gynecomastitis, menstrual irregulation, as well as sexual dysfunction. So digitals may be used as well, but we should avoid herbal teas, high fiber intake, and excessive amount of vitamin D. Also including adequate amount of potassium and taking the medication 30 minutes before meals should be instructed to all patients. And for herbs, any products that contain natural licorice should be avoided in this condition to avoid any side effects. And for the nutrition counseling, we should explain altered sodium and potassium requirements, teach the principles of DASH diet, and have the patient avoid fasting, skipping meals, as well as fad dieting. So provide receive suggestion and avoid consuming large amount of real licorice, which can aggravate the condition in this case. And for foodborne illnesses, we should teach the patient about appropriate sanitation and food handling procedures. Another condition is pheochromocytoma. This is a rare tumor of the chromatin cells, most commonly arising from the adrenal medulla, resulting in increased secretion of epinephrine and norepinephrine. So it is slightly more common in males, and the hereditary forms are typically intra-adrenal and bilateral conditions, and patients will typically present at a younger age. So PHO can occur as a single tumor or multiple growth conditions, and symptoms and signs will include very high blood pressure, headache, excessive diaphoresis, and palpitations. So some of the least common symptoms include anxiety, chest pain, fatigue, weight loss, abdominal pain, and nervousness. And about 10% of these tumors are malignant and can spread. So persons who have difficult to treat hypertension have onset before the age of 35 or after the age of 60. Or even those who are taking 4 or more blood pressure medications that may need to be tested for this condition. So the blood pressure often will fluctuate up and down, and daily testing is recommended to ensure the optimum control of blood pressure. Also, diagnoses include measurement of urinary catecholamines or their metabolite, as well as vinyl mandelic acids and total methanophrines. Also, the urinary metaphrines can provide a highly sensitive clue to the presence of this condition, and treatment usually involves surgical removal of the tumors. And before surgery, having alpha-adrenergic blockers may be used, while after surgery, about 1/4 of the patients will still suffer from hypertension and will require lifelong management of the condition. So for the intervention objective, we need to prepare the patient for surgery to remove the tumor. And if the patient with the preoperative endocrinopathies present a challenge because of their endocrine axis that is complex, and if the tumor cannot be removed, then lifelong medication will be needed. So some of the common medication of the catecholamines, the first is the dopamine, which is a neurotransmitter found mainly in the brain. So it is metabolized by the target tissue or by the liver to become inactive substance that appear in the urine. While for norepinephrine, which is a brain also neurotransmitter, it has major hormones secreted from the adrenal medulla in response to low blood glucose, exercise, and various forms of stress. Also, norepinephrine, the primary neurotransmitter, is the sympathetic nervous system. It is also found in the brain, and in the urine, it becomes norepinephrine and vinylminidolic acid. So we need to assess their levels in order to ensure that the patient has the best outcome. And for the intervention objective, we need to stabilize the blood pressure before surgery. Also, avoid overstimulation from even slight exercise, cold stress, or emotional upset. In addition, we should correct the nausea, vomiting, and anorexia, as well as managing the long-term hypertension and the severe blood pressure, if any is present, if any reading is above 180. Also, we should prevent hypertensive crisis, which could cause sudden blindness, kidney failure, or seizures, acute respiratory distress, arrhythmia, or even stroke. Also, we should manage any complications such as heart attack or cardiomyopathies. While for food and nutrition, for the urine testing, some of the doctors will order BMA diet where the patient avoid banana, caffeine from any sort of type, such as coffee or soft drinks, and even tea. While this was common practice in the past, there is no strong evidence to support the use of this intervention currently. So increased fluid, but avoiding caffeinated beverage is recommended. Also avoiding any tyramine-rich diet, especially if it was taken with MAO inhibitors medication. In addition to this, having 6 small feedings may be better tolerated than 3 larger meals. So increasing the protein and calories if the patient is having surgery is recommended, as well as post-operatively, we need to provide adequate vitamins and minerals for wound healing. And having re-expansions of the plasma volume may be accomplished by the liberal salt or fluid intake with the use of the alpha-1 adrenergic receptor or antagonist. Also, in recurrent cases, long-term drug therapy will be needed, and monitoring for specific dietary changes and side effects is recommended. And the common medications that are used with cochicolamine can be used in excess and mandatory. So the phenoxylamine is needed to block the alpha-adrenergic activity, and having diuretic should be avoided in this case, as well as low doses of beta blockers such as propanol that are used to control the blood pressure levels. In addition, it can be used for the cardiac tachyarrhythmia, but only after the alpha blockade, and having leptolol and the alpha and beta adrenergic blockers has also been shown to be effective in controlling blood pressure and symptoms of PHEO condition. We should also avoid decongestant and amphetamines or MAO inhibitors, and having high doses of MIBGs may be used in the treatment of the malignant forms, but also can have toxic side effects, therefore should be monitored closely. And if diabetes developed, insulin may be needed in all of these cases. For herbs and potential supplements, it shouldn't be used without discussing it first with the physician. And for the nutrition management and education, we need to discuss the avoidance of caffeinated food and beverage, such as coffee, tea, as well as chocolate. So maintaining a calm atmosphere for the patient to prevent undue stress is always recommended, and encouraging the patient to exercise should be limited until the condition is under control. Therefore, the patient can start their exercising schedule. And for foodborne illnesses, we should teach the patient about appropriate sanitation processes and food handling procedures. For hyperthyroidism and its concept from a nutritional point of view, we need to first understand how the condition developed and how we can manage it accordingly. So hyperthyroidism results from oversecretion of the thyroid hormone, the triiodothyronine, and or even the thyroxine. So this hormone can affect every cell through controlling the body temperature, the heart rate, metabolism, and production of calcitonin. So thyroid hormone will affect the glucose homeostasis through increased hepatic glucose output, in addition to increased fluid cycling, volatile cycling of the glucose degradation products between both the skeletal muscles and the liver. Also, decreasing glycogen store in the liver and the skeletal muscles can develop and altered oxidative and non-oxidative glucose metabolism and decreased active insulin output from the pancreas and increased renal insulin clearance can develop. So when the hypothalamus signals the pituitary gland to produce TSH, normally this is regulated to be just enough in this condition. But the autoimmune thyroid disease and Graves' disease, in addition to the chronic lymphocytic thyroiditis, are among the most common endocrine disorders in childhood and adolescence. So the autoimmune thyroid disease will usually have hyperthyroidism with the entire gland overproducing thyroid hormone, and rarely a single nodule is responsible for the excessive hormone secretion. So an elevated metabolic rate, tissue wasting, diaphoresis, tremor or tachycardia with goiter, heat intolerance, and cold insensitivity with nervousness, increased appetite, and exothalamus with loss of glycogen stores can develop. So if left untreated, atrial fibrillations and osteoporosis can result in this case. And the thyroid test result, it should be high in the TSH, T4 is normal, and T3 is normal. Then this will mean that the patient have a mild subclinical hypothyroidism. But if the TSH is high and the T4 and the T3 are low, then the hypothyroidism will be mild in the subclinical condition. Also, a low TSH with normal T3 and T4 is also the mild form, and the low or high to normal T3 and T4 is hyperthyroidism, and having low of all of the three hormones, then this the non-thyroidal illnesses with rare pituitary hypothyroidism. So autoimmune thyroiditis may start out temporarily, then will lead to hyperthyroidism. And the most common cause will include Hashimoto's thyroiditis, subacute granulomatous thyroiditis, or silent lymphocytic thyroiditis. So the major environmental trigger of ATID include iodine, medication, infection, smoking, and possibly stress as a resulting factors or causing factors. So specific digestive diseases, including celiac disease or primary or biliary cirrhosis, may be associated with autoimmune thyroid processes. So for persons who have type 1 diabetes, mood disorders, psychosis, or even Addison disease also seem to be at a higher risk for developing thyroiditis and hyperthyroidism. And in Graves' disease, this is the most common form of thyrotoxosis and is more severe. Also, clinical thyrotoxosis in Graves' disease patients is caused by thyrotropin receptors stimulating autoantibodies. And most people who develop Graves' disease have one or more of the following symptoms, including dry or itchy eyes, a string of bug-eyed look, as well as sensitivity to light, excessive tearing, feeling of pressure around the eyes, difficulty in closing the eyes completely, and peripheral double vision. So thyrotoxosis can alter the carbohydrate metabolism in a type 2 diabetic patient to such an extent that diabetic ketoacidosis will develop if this wasn't treated. And for thyroid storm, which is the thyroid crisis, it is a potentially life-threatening condition that develops in persons with hyperthyroidism. So the gland suddenly releases large amount of thyroid hormone in a short period of time. And signs of thyroid storm include extreme irritability, high systolic blood pressure, low diastolic blood pressure, tachycardia, nausea, vomiting, diarrhea, and high fever with confusion and sleepiness. Also, shock, delirium, shortness of breath, fatigue, coma, and heart failure, or even death in extreme cases can result if the condition wasn't treated. And the emergency medical treatment is always needed in this case to ensure the best outcome for the patient. Also, if thyroidectomy is needed in this case, then using antithyroid agents in addition to iodine are often given every 4 to 6 weeks before the surgery to minimize the risk of the thyroid crisis. So with thyroidectomy, the patient may require a high caloric diet, high protein uh, in the preoperative period. In addition to this, evaluating the need for post-operatively with the doctor's care plan to ensure that the patient has the best outcome at all cases. So to achieve an euthyroid state and avoid the effect of the triiodothyronine hormone on the heart and the cardiovascular system, we should decrease the systematic vascular resistance and increase the resting heart rate with the left ventricle contractility, the blood volume, in addition to the cardiac output. So to prevent or treat the complication, we need combining the high metabolic rate, including the bone demineralization. It seemed to be a greater problem in specific in older women than in adolescents. So replenishing the glycogen stores and replacing the lost weight that is usually between 10 to 20 pounds is recommended. And for the intervention objectives, we need to correct the negative nitrogen balance, replace fluid losses from diarrhea, diaphoresis, and the increased respiration. And however, the exophthalmos that is caused by increased accumulation of the extracellular fluid in the eyes, it can require fluid restriction and salt restriction. We should also monitor or treat fat intolerance and steatorrhea if it was present. And for food and nutrition, we should use high caloric diet, and the patient caloric need may be increased by about 50 to 60% in this condition. And we should also ensure that the patients have adequate intake of carbohydrates, as well as providing protein in the range of 1 to 1.75 gram per kg of the body weight. Also, fluid intake should be about 3 to 4 liters per day, unless this was contraindicated by renal or cardiac problems. Also, we need to include about 1/4 of milk or equivalent on a daily basis to supply for adequate calcium, phosphorus, and vitamin D. We should also exclude caffeine and stimulant from the diet because they can aggravate the excitability of the and nervousness in these patients. So supplementing the diet with vitamin A, C, and B complex, especially thiamine, riboflavin, B6, and B12. So a general multivitamin mineral supplement can be beneficial, but we should monitor for iodine content in these medications. And we should be aware of the iodine in any supplement that is used, as chronic iodine intake greater than 500 microgram are associated with adverse effects in this condition. Also, having grown natural goitrogens such as cabbage, Brussels sprout, kale, cauliflower, and soybean shouldn't be used with the anti-thyroid medication because these substances can increase the side effect of the medication. But cooking can reduce this effect to a greater deal. So some of the common drugs that are used and their potential side effects, as the goal of the drug therapy is to prevent the thyroid from producing excessive hormone. Having anti-thyroid medication, also called thyronamide, such as methylozamide and the blogrothize, can cause nausea, vomiting, and altered taste sensation. Also, it can cause gastrointestinal distress. So they should be taken with food only, and we should avoid the use of any natural goitrogens in raw forms and also in the cooked forms that are cooked to a sufficient degree that this wouldn't cause a problem. So thiamine represents the treatment of the choice in pregnant women and during lactation in children and adolescents and in the preparation of radioiodine therapy or in the thyroidectomy cases. And in the radioactive iodine that may be used to damage or destroy some of the thyroid cells, it can cause a temporary burning sensation in the throat, and having HCTZ medication may be used to improve the radioiodine uptake in hyperthyroid patients but we need to replace the potassium losses with this medication. So some drugs can affect the thyroid gland, and amiodarone, which is a potent antiarrhythmic medication, which also possesses beta-blocking properties, and it can contain amount of iodine that is 250 times of the recommended daily iodine requirement. So the amiodarone-induced thyrotoxicosis is a difficult condition to diagnose and to even treat, but we should monitor for it carefully in patients using these medications. And for herbs, it shouldn't be used without discussing with the physician, but having vibra, lemon balm, and kelp have been recommended, but no clinical trials have proven their efficacy. So we should limit the use of large quantities of iodine-rich seaweed, such as kombu, to avoid side effects. And for the nutrition education and counseling, the thyroid hormone effects on the adipokines and the adipose tissue, therefore predisposing the patient to ketosis. So we should be aware of hyperglycemia after carbohydrate-rich meal, and we should encourage having a quiet, pleasant mealtime to avoid any stress. In addition to this, frequent snacks may be needed, and to avoid obesity, we should adjust the patient diet as condition corrects itself. And for foodborne illnesses, we should teach the patient on food handling procedures. So hypothyroidism is caused by the under-functioning of the thyroid gland, and it can be classified as primary thyroid failure or secondary from pituitary TSH deficiency. Or it even can be tertiary from hypothalamic deficiency of the thyrotropin-releasing hormone. Or it can even result from peripheral resistance of the action of the thyroid hormone in itself. So a primary hypothyroidism causes about 95% of all cases. And the most common causes of thyroid gland failure is hashimoto-thyroiditis, which is an inflammation caused by the patient's own antibodies, as in the case of pernicious anemia, lupus, rheumatoid arthritis, diabetes, or even chronic hepatitis. So the second major cause of thyroid gland failure is from various medical treatments that affect the thyroid gland. So hypothyroidism can affect up to 10% of all adult women, and usually middle-aged and older women in specific. So women may experience menstrual irregulation or difficulty in conceiving. And the triiodothyronine and thyroxine are elevated during pregnancy and with the oral contraceptive and estrogen use in specific. So physicians must treat hypothyroidism to avoid long-term complications such as depression, infertility, and CVD. So the risk decreases if thyroid hormones are taken as directed. And for the congenital hypothyroidism or the creatinism is a rare condition, and the incidence is about 1 in every 4,000 live births. So screening for this type of hypothyroidism is now common. And the treatment involves replacement of thyroid hormone and iodine. Also, creatinisms can occur in areas where the soil content of iodine is low. Also, myxedema is a non-pitting edema that can occur in adults with hypothyroidism, and the hydrophilic mucosal accumulate in the skin as well as in the muscles. So in the end-stage myxedema, untreated hypothyroidism will lead to progressive weakness, stubborn behavior, hypothermia, hypoventilation, and hypoglycemia with hyponatremia, and water intoxication or even shock. And in severe cases, it can even lead to death. So it occurs most often in older patients with underlying pulmonary and vascular disease. So the thyroid autoimmunity is common and may contribute even to miscarriage as well as to hypothyroidism. So infants are totally dependent on the T4 from the mother during the first trimester for normal neurological development. And the hypothyroidism from autoimmune disease or suboptimal iodine uptake occurs in about 2% of all pregnant women. Also, the postpartum thyroid dysfunction occur in about 5 to 9% of women. So because of the potential problems for the mothers and the baby, screening, diagnosis, as well as treatment of the thyroid problems among the pregnant women is of very high importance in this specific condition. So in the endemic goiter, this is an enlargement of the thyroid gland with swelling in front of the neck resulting from the iodine deficiency due to inadequate dietary intake of the drug effect. Also, over 3 billion people in the world are on iodine supplementation programs. And optimal level of the iodine intake to prevent thyroid disease is in a relatively narrow range around the recommended daily iodine intake of 150 micrograms. So the subclinical hypothyroidism is considered as a mild thyroid failure and is diagnosed when the peripheral thyroid hormone levels are within the normal reference laboratory range, but the serum TSH levels are mildly elevated. So iodine, iron, and selenium with the zinc deficiency can impair the thyroid function. Also, iron deficiency will impair the thyroid hormone synthesis by reducing the activity of the heme-dependent thyroid peroxidase. So, iron supplementation may improve the efficacy of the iodine supplementation. And anemia is a major manifestation in the hypothyroidism, not only because of the impaired hemoglobin synthesis, but also because of the iron deficiency from increased iron losses with menorrhea, impaired intestinal absorption, as well as folate deficiency due to impaired intestinal absorption of folic acid. Also, Bermucus anemia may develop with vitamin B12 deficiency, and selenium deficiency with disturbed thyroid hormone status may develop in the case of phenylketonuria, as well as from the poor nutrition in children and elderly people or even sick patients. So, in parts of the world where iodine and selenium are both deficient, then having dual supplementation may be advisable. So, the symptoms of the hypothyroidism by the lab stages, for example, in infants, these can include constipation, cyanosis, developmental delay, horse's cry, and marked in specific retardation of the bone maturation, as well as persistent jaundice, poor feeding, respiratory difficulty, or somnolence and umbilical hernia. While in children, evidence of mental retardation, as well as poor performance at school and retarded growth with stunning or short stature can develop. And in adults, this can manifest as abnormal menstrual cycle, brittle nails, broad flat nose, coarse feature with protruding tongue, dry hair, cold intolerance, or even dry, rough, and pale skin, and decreased libido or delayed retention, and difficulty in losing weight. So, vitamin A deficiency and the iodine deficiency disorders can affect more than 30% of the global population of the world, and these deficiency often coexist in vulnerable groups. So, given alone without iodine repletion, high dose of vitamin A supplementation in combined VAD and ID may reduce the thyroid hyperstimulation and reduce the risk for goiter. So, more research on vitamins and mineral therapies will be beneficial. And for the intervention objective, we need to control the weight gain that results from 15 to 40% slower metabolic rate, especially if the untreated patient have this condition. So measuring weight frequently to detect fluid losses or retention is advisable, as well as correcting the underlying causes such as inadequate intake of iodine or congenital deficiency. So in this case, hormone replacement therapy should be given. Also, correcting vitamin B12, folic acid, or iron deficiency anemia when present, and because vitamin D3 has implications in autoimmune disorders, assuring adequate intake in the diet and supplementary sources as needed is advisable. In addition to this, improving the energy level, reducing fatigue is recommended, as well as improving the cardiac, the neurological, and renal function. So, screening for thyroid problems in pregnant or postpartum women is recommended, and assuring that hormone replacement therapy is used as indicated. While for food and nutrition, we should use an energy controlled diet that is adjusted for age, gender, as well as height. In addition, having multivitamin mineral supplementation formula may be beneficial, especially to replace the nutrients that have been poorly absorbed. And since T3 is an important hormone that is needed for vitamin A metabolism, its serum level should be checked, and as it can be low in this population. So, including good source of carotenoids such as lycopenes is recommended. Also, we should ensure an adequate supply of antioxidant and fiber-rich diet as well as fluid is present at all times. And for pregnant women or for children, we should make sure that they have adequate amount of iodine being consumed. So the natural goitrogens in cabbage, turnip, seed, and peanut, and also soybean, may block the uptake of iodine by the body cells, and they are inactivated by heating and cooking. So achieving optimal iodine intake from iodized salt to minimize the thyroid dysfunctioning is recommended. Also, supplying the patient with zinc, copper, and tyrosine are needed. Also, we need to ensure adequate iodine status during parenteral nutrition, in particular, in preterm infant is present at all times. So for the medication, the thyroid hormones are used as a replacement therapy and used with caution, in specific the use of soy protein products since they can decrease the effectiveness of the hormones. Also, the thyroid hormones elevates the glucose and decreases the cholesterol level, but we should monitor persons who have diabetes carefully. Also, monitoring for weight changes and fluid shifts, and if a rapid weight loss present with sweating or other symptoms of hyperthyroidism occur, then the doctor should be contacted for immediate follow-up. Also, lithium treatment for bipolar disorder has been associated with the development of goiter. Therefore, we should monitor the patient closely. So for herbs, it shouldn't be used without discussing it with the physician first, but avoiding kelp tablets and thyroid support supplements and gelatin, walnuts, mustard, or radish have been recommended. But there are no clinical trials that have proven the efficacy of these medications. So, chromeins and vitamin A, B12, D3, and E may be beneficial in this case, and longer human studies are needed to determine their exact role. So, if large quantities of iodine-rich seaweed, such as kombu, are consumed, then use should be monitored in patients who take thyroid replacement hormone in specific. And for the nutrition education and care management, we should discuss goitre genes in the cabbage, some vegetables, turnips, and peanuts, as they are inactivated by heating and cooking. Therefore, the patient should be instructed on the appropriate cooking process. Also, encouraging the use of iodized salt as permitted and avoiding self-medication with iodine supplements, in addition to encouraging adequate fluid intake in these patients. And for women who are considering pregnancy, they may want to be screened to rule out any thyroid problems. And if their iodine intake is low, or if they live in an area without the use of iodized salt, then they may need an iodine supplement prescribed from their physician. So a normal urinary iodine level would be between 150 up to 250. So, in many developing countries, children are considered at a high risk for iodine deficiency, also for VAD and iron deficiency anemia. Therefore, we should select the appropriate supplement in these cases to have the best medical outcome for these patients. So, because the subclinical hypothyroidism is common in individuals who have chronic kidney disease, then close monitoring of the GFR is recommended. Also, exposure to large doses of metals such as lead, molybdenum, or arsenic acid may reduce the thyroid function. Also, with adverse effects on the development, behavior, metabolism, and reproduction. So the parathyroid glands have an overall regulatory role with the actions as thermostators in the systematic calcium homeostasis. This is done to ensure a tight regulation of the serum calcium concentration as well as the appropriate skeletal mineralization. So the parathyroid hormone can affect the calcium, phosphorus, and vitamin D metabolism by removing the calcium from bones to raise the serum level. Also, it promotes the hydrolyzation of vitamin D to its active form. So calcitonin, in contrast to the BTH, decreases the serum calcium levels as it is secreted by the thyroid gland. And the body secreted BTH in response to hypocalcemia or hypomagnesemia. And the hormone will then stimulate osteoclasts to increase the bone response to the medication. So BTH also stimulates adenyl cyclase to increase the renal tubular calcium resorption, and phosphate excretion. And BTH will work with vitamin D to regulate the total body calcium by activating the conversion of the inactive vitamin D to the active form. So the active form, which stimulates calcium and phosphate absorption from the GIT. So calcitonin, in contrast to the BTH, will decrease the calcium level and is secreted by the thyroid gland. And the fibroblast growth factors is a hormone that regulates the mineral and vitamin D metabolism. So research on the effect of various genes and hormones in the bone homeostasis are still ongoing to assess for the best outcome and impact for these conditions. So for hypoparathyroidism and hypocalcemia, first of all, hypoparathyroidism results from deficiency of the parathyroid hormone due to biologically ineffective hormone. It can also be due to damage or accidental removal of the gland or due to an impaired skeletal or renal response. So in the hereditary form, parathyroid glands are either absent or not functioning properly, and the symptoms appear before the age of 10. So other causes can include magnesium deficiency or even neonatal immaturity. And if it was untreated, hypoparathyroidism retardation dysmorphism may result. So cancellous bone in the hypoparathyroidism is an abnormal suggestion that parathyroid hormone is required to maintain the normal tubercular structure. So hypoparathyroidism with hypocalcemia is one of the most common results of damage to the parathyroid gland during surgery. So in fact, it may even be diagnosed during a workup for hypocalcemia. So vitamin D levels may also be deficient in this case. and intraoperative BTH level are used widely during the parathyroidectomy as an indicator of the parathyroid gland function. So vitamin D supplementation after surgery may be given to anticipate the decreased parathyroid gland function and to even avoid the symptomatic hypocalcemia. So hypoparathyroidism is a chronic condition that requires lifelong treatment with large doses of calcium and vitamin D supplements. So episodes of tetany are treated with calcium that is given intravenously to provide quick relief of symptoms. Also, controlled release of physiological concentration of the BTH can be achieved using a surgically implemented controlled release delivery system. So the intervention objectives include normalizing the serum and urinary levels of calcium, phosphorus, and vitamin D. So to prevent lifelong term complications such as cataract, pernicious anemia, and Parkinson's disease and bone diseases. So preventing mental retardation or malformed teeth in affected children is recommended. And decreasing the symptoms of tetany and improving the overall health status is one of the primary objectives. For food and nutrition intervention, we should use a high calcium diet with dairy products, including nuts, salmon, peanut butter, broccoli, and other green leafy vegetables. So, if tolerated, lactose should be included in the diet for better absorption of calcium. Also, oral supplementation that is high in calcium should be used, such as calcium carbonate. And to reduce the excessive use of meat and phytate from whole grains and oxalic acid, such as in spinach, chard, and rubber, if the diet contains large amount of them. Also, the intake of vitamin D and protein should be adequate, at least meeting the recommended daily allowance. So for the common medication used, these should include calcium lactate, calciferol, which is vitamin D analog that is used when the calcium supplement in this condition. Also, calcitrol can be useful in most cases, and having diuretics sometimes should be given to prevent too much calcium from being lost through the urine, which can be a problem that can lead to kidney stones in some cases. Therefore, diuretics will also reduces the amount of calcium and vitamin D supplement as needed. So overuse of steroid may causes hypocalcemia. Therefore, it should be monitored closely. So for herbs, it shouldn't be used without discussing it first with the physician. And for nutrition education and care management, we should indicate which food are good sources of calcium, phosphorus, and vitamin D. And we should indicate which food are sources of pH and should be avoided, and if the dietary intake is concerned in these specific cases. Also discussing the role of sunlight exposure in vitamin D formation and how it can relates to the individual needs. And for food burn illnesses, if the patient is using home tube feeding, then we should teach them on appropriate sanitation and food handling procedures. So we'll be taking a break now for Salat al-Maghrib and then continue our discussion.
Assalamu alaikum wa rahmatullah. Welcome back, everyone. We will continue our discussion with the lipodystrophy syndrome. So the objective is to review the lipodystrophic syndrome and the classification and the clinical feature of the lipodystrophy, as well as focusing on HIV-related lipodystrophy and the management of the metabolic complication with the novel treatment options. So first of all, what is lipodystrophy? It is defined as a heterogeneous group of rare acquired and inherited disorders that are characterized by selective loss of adipose tissue, which is the lipotrophy. So in some cases, there is accumulation of fat lipohypertrophy in other regions of the body, and the generalized versus localized versus partial lipodystrophy depending on the location of the fat disposition. The complication can include cosmetic complication, insulin resistance, as well as severe hyperlipidemia, fatty liver, polycystic ovary disease, and increased metabolic rate with nephrotic syndrome in some cases. So the extent of the lipotrophy correlates with the severity of the metabolic abnormalities that are associated with the condition. So the strong bond between the fat loss and the metabolic abnormalities demonstrate the significance of the adipose tissue as a dynamic endocrine organ in specific. While for the adipose tissue, it is a highly active metabolic endocrine organ that mainly composed of adipocytes, but also is an intrinsic network of connective tissue, nerve cells, somavascular cells, and immune cells as well. So the adipose tissue is extremely responsive to hormonal signals and to the demand of the CNS, including secreting 6-steroid and glucocorticoids. So insulin and steroid will induce the transcription factors from both the pre-adipocytes to being differentiated into a standard adipocyte. And once there is an excessive amount of substrate or food available, the lipid droplets from within the adipocyte and then subsequently differentiate the adipocyte levels of maturity. So the adipose tissue or the lipid droplets are considered as a small organelles which stores the triglyceride intracellularly, and in which they can form as fizzles within the endoplasmic reticulum that fuses and accumulates. And as these droplets grow in size and bulk, the adipocyte increases in bulk, and this process is essentially reversed in periods of fasting or starvation. And the normal adipose tissue will protect against the lipo and the glucocytotoxicity via the adipocyte differentiation process. So the mechanism of the disease for the adipocyte, it provides a place to store the lipids, and when these cells are absent, the lipids will then accumulate in the muscles, liver, and other areas of the body. So this accumulation of triglycerides is thought to cause the metabolic instability, including insulin resistance, hepatosteatosis, and often cirrhosis. And the classification of lipodystrophy is divided into two forms, the congenital and the acquired form. In the congenital form, it also divides into generalized and regional subtype. For the generalized type, It is called generalized congenital hyperlipodystrophy, and it is monolobical dysplasia with autoinflammatory syndrome. Also, the MBD syndrome is referred to as this condition with neonatal Brognoid syndrome. While for the regional type, it is an autosomal dominant familial partial lipodystrophy that is known as Dunning syndrome, and also the short syndrome. While for the acquired type of lipodystrophy, this is generalized AGL, but the regional is the HIV-related lipodystrophy and autoimmune disorder. So the localized form are the localized lipodystrophy that is induced due to medication or penicillitis, pressure, and idiopathic diseases in some cases. Also, the congenital generalized lipodystrophy can be associated with some metabolic abnormalities, including insulin resistance that is typically seen in early ages. Also, the DM usually develop in teens with ketosis that is very rare. So, DM usually is refractory to insulin in this condition. And there is also the hypertriglyceridemia that is associated with pancreatitis, as well as the serum leptin that is low in most cases. And it is consistent with near total absence of the body fat in general. While for the congenital partial lipodystrophy, there is a familial type and the Werner syndrome. The familial type can be divided into four more categories with clinical features of loss of subacute adipose tissue from the extremities and the trunk. Also, the loss of the subacute tissue from the extremities only, and the loss of subacute adipose tissue from the extremities with fibrotic adipose tissue. While for the Werner syndrome, this is associated with skin changes like bird-like facials and bilateral cataract with short stature and neoplastic changes. And for the associated metabolic abnormalities, these will include dyslipidemia by increased level of LDL and triglyceride while having a low level of HDL. So certain BLS may increase triglyceride synthesis, but the variability between the individual agent is present in most cases. So in addition to this, the increase in the visceral fat and the reduction in the lower body subcutaneous fat independently are associated with dyslipidemia. So for diabetes insulin resistance, the risk is increased in the heart-treated HIV-infected patient that is compared to HIV uninfected controls patient. So, though to be multifactorial in the etiology with contribution from HIV itself, also a patient-related factors such as genetic, weight, or lifestyle, as well as the antiviral, antiretroviral therapy that can be used in some patients. So the treatment consideration include stopping or switching the HART medication, as well as lipohypertrophy and lipoatrophy with dyslipidemia and insulin resistance or diabetes that can develop during the treatment course. Therefore, should be monitored very carefully and managed accordingly. Also, we should stop or switch the HART medication. And for example, in a study of AIDS patients that included 26 Caucasian men with HIV type 1, they had a viral load of 500 copies and had an intervention of interruption of the HART medication for 7 weeks. So the measures included lipid, glucose, and insulin level with 24-hour urinary free cortisol. And after the study, they concluded that relatively a brief interruption of these medications resulted in significant improvement in the total cholesterol level.